Welcome to the second Wellness Diwaniya. We're happy to see such a huge crowd as we did last week and hopefully for the next coming ones. I don't think I need to give an introduction to Dr. Mohammad. I believe everyone's here to listen to him today. And here we are going to be talking about the relationship between the physiology with mental health.
Right.
So to start off, can we just understand what is, if you are going to define what is the relationship between physiology and mental health, what it would be simply?
So it's a good question to start with. So, you know the saying, healthy mind, healthy body, right? Or you could flip that around and say healthy body, healthy mind. Really, the mind and the body are, you can't disentangle them from each other. It's really one and the same. So when we say physiology, it's all the biological functions within the body and the organs and what they produce and what actions they do and how they interact, leading to what becomes us. And the computer of that system, of the physiological system, is the brain. So all your thoughts and your dreams and your aspirations and your relationships and your actions, your motor functions, your feelings, your emotions, your ups and downs, your perception of this moment is all programmed through your brain. And so the brain is being connected to every other part of the body, the special senses, your eyes, ears, and so on, and then also to the rest of your physiology, and vice versa. So there's a bidirectional effect. And so it's always interesting to me why we think about mental health differently. And I think it goes back to the philosophy of Descartes, which, he had this Cartesian dualism where the mind is different than the brain. And today we know it's the same. The brain is the mind and the mind is the brain. And therefore, physiological health is mental health and mental health is a form of physiological health.
If you say the mind and the brain as were seen as two different things, is it the same as saying there's the subconscious that we cannot control and then the conscious that is 5% of what we can control?
Yeah, I wouldn't say it's 5%, but so the unconscious is part of your brain. It's just not part of your consciousness. Now, consciousness is a huge mystery. It's been written about a lot, and we don't fully understand it. But even the unconscious functions are part of the brain. And in some ways, we can think about the processes in our body as unconscious functions, right? I mean, we don't really control our heart rate. You could train yourself to through biofeedback and mindfulness and so on. We don't really control a lot of the other physiological functions in our body. Is that part of the unconscious? To me, the unconscious is all these automatic systems that are happening throughout the body, and the automatic part of the brain that you're not fully aware of, that's the unconscious. And so that doesn't lead to the mind being separate than the brain. The danger with separating the mind from the brain is that we see it as this supernatural thing that isn't affected by physiological health and therefore is only affected by something non-materialistic, maybe only spiritual, and that leads to, and I'm not saying there's no spirit, but what I'm saying is if the danger of going solely in that direction is to think about a lot of the things that happen in our mental process, whether good or bad, not being under our control in terms of our health, and therefore not seeking help when you need it, which happens a lot in mental health.
Would you say that's one of the biggest misconceptions about the relationship between physiology and mental health?
It probably is the biggest misconception.
What else would?
Common misconceptions about the relationship between mental health and physiological health?
Yes, and how you can affect or I don't want to say control, affect how you think and how you feel, mainly.
I mean, let's go through some numbers. So, very common medical illness, diabetes, very common in Kuwait. It's been shown very clearly in multiple different cultures that about 1/3 of patients with diabetes will develop depression at some point in their diabetes. Whereas the normal rates of depression are around 8% of people, so much lower than that. So let's take an illness like chronic pain, chronic back pain or anything like that. About 50% of people with chronic pain will develop depression. And people who have depression will experience chronic back pain or any chronic pain more acutely. So there's a very clear relationship. So to really kind of think of them as separate has no accuracy whatsoever. And so I do think that is the most common misconception. The other common misconception is that if you have a mental illness, then it's something that is incurable or it's going to be there forever. Or if you need to cure it, then you shouldn't seek the medical route. You should only, because the medical route is only going to make it worse, right? That's a very common misconception. Or that the medical route only entails medication. We wouldn't say that about diabetes. The medical route to treating diabetes is not only medication. And we wouldn't call treating diabetes nutritionally as an alternative medicine, and yet treating mental health nutritionally we consider it as an alternative medicine. I think the whole term alternative medicine is false. Medicine is medicine, okay? Anything that has evidence is medicine. Aromatherapy is medicine. Massage therapy is medicine. Chiropractic is medicine, right? They're not alternative medicine. It's all medicine. Anything that has proof. And so the point, that's a big misconception, that you need an alternative route to treat mental health, whereas you don't need an alternative route to treat diabetes or so on, where it's all holistic. It all comes together.
Before going into the alternative, you made a very good point about it being completely mental, and I want to look at the genetic components of, so this is now the new trend, which is to check on any SNPs in your genes.
Yeah.
A lot has been done about genome sequencing and looking at that kind of thing. And also things like some parts which are very common, more than, I'm just quoting a study, more than 40% of people walk around with a gene mutation in the COMT or MTHFR, which are the methylation, let's say, sequences. And that, because of that methylation issue, they have mental problems. That's why a lot of people are anxious today.
I think that's all correct, but also too broad, right? So the COMT gene and the MTHFR gene variations are very common, and most people who have a COMT variation or MTHFR variation, or for that matter, a serotonin transporter protein variation, these are all variations you can have in your genome. And just to explain to the audience, SNPs means single nucleotide polymorphisms. So in your genome, which is basically a map, sometimes you can have little errors in that map. Think about Google Maps having labeled something incorrectly or saying it's closed when it's open, or that would be a SNP. Okay, so that's a single nucleotide polymorphism. But see, the danger, and mental health is very affected by your genes, but the danger of reducing it to a genetic polymorphism is to say that we have no control. Whereas the science of epigenetics says, well, it's not only the map, it's how you read the map, it's how the map is translated, it's how the map is displayed, and what route you follow on that map. And so you can have two people with the same genetic variations, the same SNP, and because of their environment, whether it's their social environment or their built environment, and built environment is very important, I'll come back to that, they'll have completely different manifestations related to that genetic programming. So the penetrance of the gene, the manifestation, the phenotype. So you can have a genotype, which is how you're mapped, but then the phenotype is what actually manifests, can be very different based on what happens in your environment. So it's really the genetic environmental interaction. And just to conclude that point, so when we say environment, we mean social, physical, and built environment. So social environment obviously is affected by the way you're raised, if you had abuse as a child, if you're in a war-torn country, if you went through bullying or being ostracized. The physical environment would be what kind of levels of radiation are you exposed to, secondhand smoke or smoking, drug use, and so on. So that would be your physical environment. And then your built environment, why is it that Denmark consistently wins as one of the happiest countries in the world? I think part of it is their built environment. They've built the nation in a way, now it helps that they're kind of a small nation, but they built the nation in a way that you can bike everywhere, and there's sidewalks everywhere, and people are moving all the time. So that's an example of engineering affecting the manifestation of your genes or your health. So that we call that the built environment. So all those different types of environment, their interaction with your genome is going to have an effect on what happens in your physiological and your mental health.
Do you feel that the term trauma has been overused?
If anything, it's been underused. I know it's become very popular now on social media, but I think in the past, and I've said this before on programs, that we used to think about trauma as just major things. major things at the level of society, natural catastrophe like an earthquake or a hurricane or a war, or something at the personal level like robbery or a sexual assault. But really, who's to say that being bullied throughout your childhood is not a form of trauma? In my practice, they sometimes have the same manifestations as someone who went through what we traditionally would think of as PTSD. Now, just because I don't think we use the term trauma enough, or that it's underused, and that's proven, by the way, it's not just my thoughts, it's there's studies showing that a lot of trauma is underreported. Underreported because healthcare providers, whether it's psychiatrists, psychologists, family doctors, and so on, are not assessing for it, and because of the shame about talking about it. Doesn't necessarily mean that you have something like post-traumatic stress disorder, right? So you can have trauma that affects what's the so-called stress diathesis model. And that model is that basically you may be vulnerable to something, and then under certain pressures, that vulnerability develops. The example I always give is seasonal asthma. For two reasons. One, I have seasonal asthma, and two, it's a very common illness that most people understand. So I'm not coughing now, I'm not wheezing. So my question to you is, do I have asthma? Right now, do I have asthma?
No.
I do.
Where you have, it's not manifesting right
Exactly, right? And so that's the stress diathesis model. So I have asthma, and if a dust storm happens now, here's the other trick question. Do you have asthma?
No.
Okay. So if we go outside and there's a huge sandstorm outside, here's the trick question. Which of us two is going to start coughing? It's a trick question.
now. Would it be me?
It's actually both of us, right?
Okay.
But who's going to have an asthma attack? It's going to be me, right? And so under stress, all of us are going to be affected. But some of us are going to have that diathesis to develop depression or anxiety or so on, just like some of us will, there's people that develop obesity but don't develop diabetes, right? Obesity is a risk factor for diabetes, but not everyone obese develops diabetes. Why is that? Well, some people have the vulnerability genes, and so when they gain weight, they will develop diabetes. And some people don't have that vulnerability gene. They may gain weight and they have the consequences of obesity, but not necessarily diabetes. And so the interaction between that vulnerability and the environment, that's what we call the stress diathesis model. That brings us back to trauma. Some individuals may go through trauma, and even though I don't think the term trauma is overused, it doesn't mean that every trauma turns into PTSD.
Okay.
Yeah.
So that also takes us back to the genetic component. You can have it, but it needs a trigger for it to actually
Exactly.
manifest.
Exactly.
So you talked about the bilateral communication between the brain and the body. And I want to look specifically at the new research, which looks at the bilateral relationship between the brain and the gut. And
Very interesting.
now
Yeah.
that actually it's slowly moving towards the gut being the brain rather than the brain being the brain.
Right.
What are your thoughts?
So the interesting thing that happens in science is when something becomes popular, suddenly it's the explanation for everything. I remember that happened with vitamin D, that happened with omega-3 fatty acids. So, as a scientist, I always say the core of religion is faith, and the core of science is skepticism, and you need both, right? And so, as a scientist, I'm a skeptic when anything like this comes up, and so this idea that the gut is the answer for everything, the gut is the brain, I think is false. Having said that, it is true that most of the serotonin produced in the body is produced in the gut, that there's a clear link neurologically between the gut and the brain, that higher levels of unhealthy bacteria have been shown to affect the manifestation of mental illnesses. A very interesting study in a serious mental illness, bipolar disorder. So when you talk about, usually when we say SMI, serious mental illness, we're thinking bipolar disorder, schizophrenia, schizoaffective disorder, those three. So one of the more serious mental illnesses, bipolar disorder, there was a study where they had patients with bipolar who developed a manic or depressive episode, were hospitalized, and they took half of them during hospitalization and started them on a standard of care treatment, lithium or an antipsychotic or one of the mood stabilizers. And then the other half got the standard of care treatment and a probiotic. And then and this was randomized, double-blinded, placebo-controlled. So the group that didn't get the probiotic got dummy pills and were told it's a probiotic. But they all got mood stabilizers. And they were discharged. And the outcome measure of that study was time to readmission. So how long does it take you to be readmitted to the hospital for any mood episode, whether depressed or manic? And they found that there are huge differences between the group that took probiotics and that didn't. Does that mean that probiotic is a cure for bipolar? Absolutely not. But is it part of the treatment package? According to that study, now in science you need replication, you need multiple studies, but at least according to that study, it's something to be further explored. It's a very strong signal that came out of that study. And there's more and more studies like that in all areas of medicine. The tricky thing with the gut health is that there's so many different types of good and bad bacteria, and really the bacteria colonies together, they create almost like an organ. They start signaling in ways that we don't fully understand. And so now we don't only need to sequence the genome of the human, we need to sequence the genome of that bacteria so that we understand those genetic interactions. I'll give you another example, not in psychiatry or mental health. Have you heard of fecal transplants?
Yes.
Yeah. So this idea, so there's an illness in medicine called C. diff colitis, very dangerous. So basically what happens is you're given an antibiotic for whatever reason, usually a very powerful antibiotic that kills off whatever bacteria the doctors are trying to treat, but then also kills off the healthy bacteria of the gut as a side effect. And what happens is you get overgrowth of a dangerous bacterial form called C. diff, Clostridium difficile. And that creates a pseudomembrane, and it can be dangerous. You can develop something called toxic megacolon, which can burst and you can die from C. diff colitis. Very dangerous condition. And the treatment for C. diff colitis is to give another antibiotic that kills off the C. diff bacteria. So you're giving antibiotic on top of antibiotic and all the consequences. So there's a study published in the New England Journal of Medicine, the most important journal in medicine, where they took a group of people and gave them the standard of care for C. diff colitis, and another group, they gave them a fecal transplant. And sorry if any of you are squeamish, but what a fecal transplant is that they take healthy feces from someone who doesn't have C. diff colitis, put it in saline, spin it, get all the, everything out, all the solid material, and that you're left with water that has bacteria from the healthy host. And then you put that water as an enema into the person who has C. diff colitis. What happened in that study, so when you do clinical trials, and I worked for a while in clinical trials, you always have an ethical committee, right? And so the ethical committee's duty is to be unblinded and observe the study. And if there's any ethical violations, you're supposed to stop the study. The researchers are blinded. They don't know which group is getting what. And that's what a placebo-controlled trial is, so that you don't have any bias in the trial. The ethical committee in this trial had to stop the trial because it was unethical not to give people fecal transplant. It was so obvious, the difference, that they stopped the study and they said everyone gets a fecal transplant because the other ones could die, right? And so it was that powerful, the study, and this goes back to the gut.
But that had other side effects. Some of them actually started gaining weight because the donor
was
overweight.
Right, yeah. Yes. And so that's, these are things you can't predict.
So it's still very new. It's
yeah, I'm not saying, by the way, I'm not saying go get fecal transplants, but
one day, but
I don't think anyone's going to be lining up to get fecal transplants.
Well, if you're having gut issues,
maybe
I think you might. But so this is when it comes to, again, goes back to, as you said, the lifestyle and what you're putting in your gut.
Yeah.
Another thing that affects is your hormones.
Absolutely.
And the hormone mental health kind of relationship is very, very dear to me, because I remember what happened with pregnancy, postpartum, and all of the phases, and it was purely hormonal.
Yeah.
And I thought it was something that happened to women, but it also happens to men.
Yeah.
Hormone issues. How is the hormone such a big factor in mental health?
Right. Well, the reason is that hormones are powerful in general. So hormones are signaling molecules within the body that usually attach to something called nuclear receptors. So there's different receptors on cells, sometimes on the surface of cells, sometimes within cells. Hormones usually attach to nuclear receptors inside a cell, inside the nucleus of a cell. And then the attachment of a hormone will change the output of that cell or that group of cells. And usually hormones, endocrinology is a very complex area within medicine because there's cascades that happen. So, for example, one of the most famous cascades in mental health is the hypothalamic adrenocortical axis. So cortisol, which is a stress hormone, can affect the hypothalamus, and you get into this zone where you're always secreting stress hormone. That's just one common example that happens in a number of things. But thyroid can affect mental health, and female and male hormones can affect. And so with pregnancy, with breastfeeding, with disordered menstrual cycles, and with men what we're now calling andropause, which is a correlate of menopause, where testosterone starts dropping in some men faster than others. You can develop mental health issues because these hormones almost always freely cross into the brain. So in the body, there's something called the blood-brain barrier, the BBB, right? And so the blood-brain barrier basically keeps things out of the brain. That's why a lot of neurological and psychiatric medications are very expensive, because pharma companies have to spend a lot of time developing not only the drug, but then how to get the drug across the blood-brain barrier. So hormones usually freely cross the blood-brain barrier, and so they're affecting not only the target organ, but they're affecting the brain as well. And so testosterone, thyroid hormone, cortisol, all the female hormones affect the brain. This is why we see mental illnesses like depression, anxiety, more so in women than men. It seems that there are some mental illnesses that are more affected by hormones, and then some don't seem to be very affected by hormones. So for example, schizophrenia or OCD, the rates in men and women are equal. And then some things you have, men are higher, like antisocial personality disorder, but that could be a cultural construct as well, because a man who's antisocial, you call antisocial personality, and a woman who's antisocial, you call borderline personality disorder, right? So, and there's studies around that too, but those are disorders that are less biological and much more psychological. So that's the issue with hormones. Now, how are hormones changing over time based on our lifestyle today, based on the way we sleep, the way we eat, the way we're sedentary all day? I mean, there's huge differences. When we used to be mobile and sleep early, wake up early, have our bodies and body clocks aligned with the circadian rhythm of the earth, all of that probably had, it's all circadian, right? It's like, so your hormones actually cycle throughout the day. That's why when we measure someone's testosterone, we have to measure it first thing in the morning, right? I've had men come to me with low testosterone. I say, what time did you do this test? Oh, I did it, do it again, 7 a.m. And you get a totally different number, right? So if we're completely disaligned from how we were, evolved to be, according to the rotation of the earth on its axis and the sun, and then we're disengaged now from how we're supposed to eat, and we've turned our night into morning with artificial lights, that I think has a very negative effect on hormones, on physiology, on mental health, heart health, so many different things.
So
what's the solution?
You said, no, not the solution. You said that
get rid of electricity and we go back to
no, we wish. Diabetes could cause depression. Because,
or let's correlate it.
Correlated,
Yeah.
Chronic pain, obviously, because of the long-term pain and everything. Does mental illness cause physiological diseases?
Well, so we don't know if either cause, but there is a correlation the other way around too. Now, what leads to that correlation, we don't know. For example, we know that patients with schizophrenia and bipolar die from cardiometabolic illnesses, so from heart attacks and from obesity, diabetes, at a higher rate than people who don't have schizophrenia and bipolar. It's so striking that if you look at the last 20 years, for example, there's a study in Sweden where they looked at the mortality rate, so the rate of death over the last 20 years, and they found that the life expectancy, as expected in any developed country, is increasing over time. So humans are aging longer and longer. And you would expect that individuals with schizophrenia and bipolar to be the same, that they're at least, even if they die at a younger age, that trend is going up with the rest of society. And what they found is that trend not only it's not even neutral, it's actually going down. So the life expectancy of people with schizophrenia and bipolar is going down while other people is going up. And when they did a sub-analysis of that, what is called a post-hoc analysis, they found that it wasn't from suicide, which was the researchers' expectation. It was from cardiometabolic illness. Now, you could say, well, okay, people with schizophrenia or bipolar, especially in depressed phases of the illness or psychotic conditions, become more sedentary. And they smoke more, they use more drugs, they eat less healthy food, they're less engaged with their society, and loneliness has been shown to increase mortality and morbidity. It could be all that, but then researchers have done studies where they control for all those factors and still find that patients with schizophrenia and bipolar die from cardiometabolic illness faster than the rate expected. So there seems to be something in these illnesses that is triggering other physiological cascades in the body. And too often we try to explain it as, okay, what is the mental illness causing in terms of behavior? And therefore, what is that behavior leading to in terms of illnesses?
Yeah.
But we forget that the brain is just another organ in the body, the most important organ of the body, so it's connected to the others. So why does the link have to be through behavior? It's partly through behavior, but partly the rest of your physiology. There's probably something that happens not only in the brain, but in the body of someone who has schizophrenia or bipolar that is linked. One of my mentors wrote a paper about this, so he's for the last probably 5 years, he's been ranked as one of the most important researchers in the world in mental health, and he's a professor at the University of Toronto where I trained. He wrote a paper called Obesity Metastasizes to the Brain. Obesity metastasizes to the brain. And so the whole idea of the paper is a theoretical paper about how being in an obese state metastasizes, just like cancer, to the brain and affects the brain in a way that then you develop these illnesses.
So like a fatty brain.
Yeah, I mean, yeah. Well, so his theory is that obesity leads to increases in inflammation,
Markers.
and then the inflammation is affecting the brain.
Yeah.
And then once the brain is in this inflammatory state, then the body is affected. It's just a vicious cycle. The body is affected as well.
Mm-hmm.
Yeah.
So would you say early prevention would mitigate those consequences? The early deaths, has that been looked into?
Early prevention of what?
Early intervention, sorry.
Yes. So early intervention, and well, you made me think of something, early prevention as well. But early intervention, 100%. So early intervention is a rule in medicine, right? So you intervene early with anything, you're going to get better outcomes. But what about early prevention? So same researcher I was talking about found that individuals with trauma tend to have higher rates of obesity. And they tend to have high rates of mental illness. And so that's another link between obesity and mental illness that's quite interesting. And so his theory is that, well, early life trauma is causing something in the physiology. That something is causing a disorder in the signaling cascade, increasing inflammation, increasing obesity, increasing cardiometabolic illness, and increasing mental illness. And so we're kind of chasing down the wrong rabbit hole, and we should be going more upstream. You know, he's an adult psychiatrist like I am, but he says maybe in some way we should all be child psychiatrists. We should all be kind of and pediatricians, and so looking early, what's happening in life, and where is the road diverging into kind of illness or health with some of these long-term physiological conditions.
So how do you, in your medical center, how do you integrate all of these things in order to educate? Because I know maybe if we look at the culture here specifically, early intervention probably is as low as it can get.
Yeah.
How are you trying to change that?
So, you know, I'm not just saying this because the Canadian Embassy is sponsoring, but because I really learned from this. So in Canada, the way medicine is, and I trained in Canada and the US and Kuwait and some training in Europe as well. Canada was unique, is still unique, that it has this idea around medical education called the CanMeds roles, which has evolved into other roles. But they see the physician as not only a medical expert, but as an advocate, as a scholar, as a communicator, and they really pioneered that. Medical education systems around the world have copied the CanMeds roles. And so I was taught at a very early age in my medical training that your role is not just seeing a patient in front of you. Your role is societal. Your role is to educate. Your role is to inform, to communicate, to collaborate. And so that's one of the things we try to do at MindWell, which is all of us participate in things like this, in activities that educate society, because how are you going to have early intervention if you're not a partner with society? One of the examples I always quote, when I worked at Toronto Western Hospital, which is a center for, and Sunnybrook Hospital in Toronto, which are centers of excellence in neuroscience. And at that time, we had stroke teams. So with a stroke, basically the blood supply is being cut off from your brain, and a clot happens in your brain, and that part of the brain is dying. And you know, people develop hemiplegia or paraplegia, and then that's it. They can never come back. But you have this window of 3 hours from the beginning of the symptoms where you can bust that clot. You can give medication that busts that clot, and it's as if the person never had a stroke. It's amazing when you see it happen. But how do you get patients in within that 3 hour window? Now, this is an extreme case. I'm going to bring it back to mental health. When I worked at Sunnybrook, I carried a stroke pager when I was on stroke team. And what you have to do, I remember when they gave me the stroke pager, so you have your regular pager when you're on call, and you have your stroke pager. And they say, if this pager rings, the stroke pager, if you're in the hospital, you come directly to where you're supposed to be. If you're not in the hospital, you get in a car or an Uber or whatever. There was no Uber at the time, but taxi. And well, I'm aging myself now, but right. But so you get on your way to the hospital. Then you call us and say, I'm on the way.
Yeah.
What happens is that stroke pager rings simultaneously with myself, with the neurology consultant, with the CT tech, with the pharmacist who's supposed to prepare the TPA, the material that busts the clot. And so you arrive at the hospital, the CT scanner stops, the patient is wheeled in right into the CT scanner, you confirm a clot, you start giving TPA right away, you ask when it started. But the key is the patient has alerted the stroke protocol. How did they do that? Well, there were ads all over the Toronto subway, and I remember some of them said, can you read this? And it looks kind of blurry. This might be a sign of stroke if you get this. And it had other signs of stroke. Now, you might get too many false positives, people calling the stroke line thinking they have stroke. But if you save one patient, and you'll never forget, I saw it in front of my eyes, that someone came in, half their body not moving, you give TPA, they're back to normal, right? And if you had missed those 3 hours, it wouldn't happen. So how do we bring that now to kind of mental health? If we intervene very early, it's gonna be a better outcome than someone spending, on average, at the Stanley Foundation in the United States, which is the Mood Disorders Foundation, they found it took 7 years before a patient admitted to a practitioner that they had a mood disorder and that they needed help. And so it starts with that. At our center, we come out into society and we want to train. Secondly, one of the studies I did with Professor McIntyre was a study where we showed less than 25% of psychiatrists ever check their patients' metabolic or health parameters. So patients at our center get annoyed because at every visit we check their height, weight, well, not height, but weight, blood pressure, and different measures. We ask every new patient to do a panel of tests. Some of them listen to us, some don't, including lipids, including markers of diabetes, and all these other markers, because if less than 25% of psychiatrists, which are doctors, they're medical doctors, are not checking, and most medical doctors are not asking about a patient's mood, so then we're working in silos. So psychiatrists need to start acting more like medical doctors, and family doctors and internal medicine and so on need to ask about mood and anxiety and so on in order for this to come together. The third thing is that you bring multiple specialties together. So ideally you'd want psychiatry and psychology working together, that you have a referral base of someone you trust who's an internist, a family doctor, a cardiologist, a geriatrician. So we have that, not currently at our center, hopefully in the future, but we have that network that we refer to back and forth. And that you're checking things, and you're treating simultaneously. So it's not you treat the diabetes and then when it gets better, then you treat the depression, or you treat the thyroid illness and then when it gets better, then you treat, you treat this and that at the same time. Because getting the depression better is going to get the other condition better and vice versa. So those are some of the things we try to implement. Now my ultimate dream is to have it all under one roof, right? And that exists in some places, but true multidisciplinary care. And by what I mean true multidisciplinary care is, again, some of the things I saw training in Canada. I remember my first rounds in Canada on patients in the psychiatry ward. There was a clinical pharmacist with us who was not trained in psychiatry. There was a chaplain with us. And then once a week, a dog was with us on rounds. It was like a pet therapy, right? So that's closer and closer to the concept of true multidisciplinary care. I think true multidisciplinary care is where the team is composed of not just psychiatry and their affiliated fields, but there's no psychiatry and there's no internal medicine. Maybe surgery would be separate, but there's no psychiatry, internal medicine, endocrinology. It's doctors round together depending on what that patient needs. They all work in the same ward.
So take away the specialization and make it more kind of a broader...
Keep the specialization, but build teams based on needs. You know who's really good at that, ironically, is the military, right? So they put together teams of specialists that is needed for this mission. And so if we have a mission to get this patient better, we don't need a public health specialist here. But if we have a mission to change our built environment, they need a health ethicist and a public health specialist and so on. So you keep specialization, but you build teams that are maneuverable and you can plug and play depending on the patient needs. So they're all working under one roof in basically not wards, other than surgery. I think surgery is is a different situation. But non-surgical medicine needs to be kind of all under one roof, I think.
So when it comes to early intervention, wouldn't it make sense to have something like this earlier on in educational institutions?
100%. 100%.
Make the kids aware of how they're feeling and make teachers aware of identifying such issues.
Yeah, 100%. So, for a long time, at least in this country, we didn't do a good job in health education. We're doing much better at that now. But I think in most countries, Kuwait and others, we don't do a good job at mental health education. Maybe in the United States, Canada, and some parts of Europe, it's getting better. Partly because they started earlier than we did in just health education in general. So I grew up in the US, and health education was a big part of growing up, and this was in the 80s. I do remember my health education classes and how important they were and how much I was informed about my own well-being. Things like learning about the dangers of smoking and the importance of healthy lifestyle, not physical education classes, like health education classes. But mental health curriculum needs to be incorporated into that. But where else it needs to be incorporated is into medical, nursing, pharmacy schools. I can tell you as a doctor who trained at a very good medical school, nutrition, public health, exercise was not a big part of our curriculum. Now, the usual excuse to that is you have so much to cover in medical school. Anatomy and physiology and internal medicine and endocrinology, and you have to learn a little bit of everything. But I think medical schools would benefit a lot from incorporating public health, nutrition, exercise into, and maybe more communication skills into medical training. That would make much more informed and broadly thinking doctors.
Yeah.
I think what changed me as a doctor was doing a public health degree. So after I did my psychiatry training and then mood disorders fellowship, I decided to get an MPH, a Master's of Public Health. And I can tell you it was one of the most important degrees I'd ever done, even though it was one of the shortest, short but intensive, because it completely changed my thinking. I would say before I trained in public health, my thinking was only about solving a problem when it happened and working with an individual or maybe a family. And so it was saving lives one at a time. Whereas the motto of the public health school where I trained, the motto of the school was saving lives millions at a time. Right? So the whole idea was, how do I assess a health system and have interventions that make a huge difference? The example they always use in public health school is there was these two doctors sitting on the side of a riverbank, and as they were sitting there, they saw a man drowning. And so they pull him out, and one of them starts CPR, and then another person starts floating down, and he's drowning. And so they pull him out and they start CPR, and then they set up this whole triage area, and they call other people, and there's like 6 or 7 people where they're all doing CPR. Then one of them is kind of just observing the scene, and they're like, oh, you need to do chest compressions, and he just walks away. He walks up the riverbank, and he finds there's a broken bridge. And so he fixes the bridge, and people stop falling in, and right? That's public health, right? And so you need both. You need that acute intervention, but I think people who do acute intervention need to learn that more upstream, how do you prevent by education, by early intervention. That's what public health is.
So what do you envision the future of mental health services?
Oh, there's so many ways I could go with this question. Look, in terms of, I think the future of mental health is more precision in terms of what doctors do. And what I mean by precision is one of the things that's a problem in mental health today is we don't have a lot of biomarkers. So we diagnose depression or schizophrenia or bipolar based on symptom criteria. Not like I know that someone has a heart attack based on their elevation of their cardiac enzymes, or I can image their hearts and so on. You can't do that in mental health yet. And so precision in diagnosis, and then also precision in treatment, using genomics to predict which treatment the person is going to react to, looking at other things like bacteria and so on. So that is going to be one of the futures. Now, how do you understand all that? AI is going to make a big difference, and we've been saying that since before ChatGPT. That used to be called machine learning. So because as scientists, it's very hard to analyze these huge databases, but you put it into an AI machine learning model, it can help you come up with these links. There was a study on this where they took brains of individuals who had depression, and this was pre-ChatGPT. They fed it into a machine learning model, and scientists had been trying to make sense of it for a long time. Within minutes, the model spit out like, there's actually 4 biotypes. And this biotype reacts to this, and this biotype reacts to that, and so in seconds, right? And so AI is not going to take over. It's going to be a tool, just like the computer or the wheel or fire, right? And so we're going to be benefiting from it. So that's the future of mental health intervention. The future of mental health systems is, I think, very close to what I described earlier, which is taking those CanMeds roles, collaboration, medical expertise, scholarliness, advocacy, communication, and putting them all under one roof, and with not just psychiatrists, psychologists, but all other medical specialties. And what we today call alternative medicine. It's really something that bugs me, the alternative medicine. Not because I'm against alternative medicine, because I think it shouldn't be called alternative medicine. Okay. I think there are things that are completely sham, and those should be not part of the medical conversation at all. But this artificial separation between what we call alternative medicine and unfortunately, now this is my bias as a MD, but unfortunately that bias comes more from the alternative medicine world than it comes from the, quote unquote Western medicine world, because it would be much more likely for someone like me who's, classically trained in the, Greek Western tradition MD to say that chiropractic and aromatherapy and massage and pet therapy and all this are part of the medical umbrella than the opposite. Someone who's in aromatherapy to say you should take medications, right? Whereas there's evidence for both.
I'm going to ask you another question that's going to bug you.
Yeah.
How do you feel about the future of treatment when it comes to new interventions such as psychedelics?
It's not going to bug me.
Okay.
Yeah. No. So there's very strong evidence for psychedelics, but it's another one of these vitamin D stories. That because there's very strong evidence and it is very promising, that it's being kind of talked about as the cure-all for everything. The other thing that I think is happening with psychedelics is that it's being romanticized a lot. So there are clear studies that treatment-resistant depression, PTSD, anorexia, OCD, some of these cases have been helped by the use of psychedelics, namely LSD and psilocybin, those two mainly, and then MDMA for PTSD. It's been approved in Australia this year, Switzerland 2 years ago. Probably FDA, it's been submitted to the FDA, probably will be approved by end of 2024, if not early 2025. My money's on end of 2024.
It's gone through all stages of...
new drug application done. It's being reviewed. I was just at the, 2 days ago, I was in New York for the American Psychiatric Association conference, and the director of the FDA was in the room, and they were talking about psychedelics, the director of the FDA psychiatry section. And she was talking about all the approvals that are being looked at, okay? So it's coming. Now, one of the things where it's being romanticized is you need the trip, and so you take the psychedelic, you go in this kind of mental journey, and then that needs to be debriefed. Whereas if you look at the science, actually the trip may not be necessary. If you give medications that block the trip, the person still gets better with their OCD, and so that's the jury's still out on that. Do you need the trip, or is it a purely chemical effect? We don't know. But I think it's going to be more of a chemical effect than the trip, because that's what the evidence is showing so far. I was at a panel where 10 CEOs of companies that are developing psychedelics for clinical use. So LSD not taking on a blotting paper with Snoopy on it, like LSD taken in a pill form, and obviously the music is not going to be less good, but what they asked them at the end of the panel is, which of you believes that the trip is necessary? Now, these guys are not only CEOs, they're all scientists. That's how they became the CEOs of these companies that are developing psychedelics or psychedelic derivatives. And 7 out of 10 raised their hand that they don't think the trip is necessary, based on the research at their companies. 7 out of 10. So that's what's happening with the psychedelic world now. Is it promising? 100%. Have I had patients that I have advised to do it? Yes, not legally in Kuwait, but I've told them to go to countries where it's legal and to do it under medical supervision, and some of them have gotten better. Not all of them, but some of them where nothing worked, medication, therapy, and so on, some of them got better. Now again, very clear, I want to say, follow local rules and regulations and approvals. But what I told these patients is go to a country where it's approved by the medical authority of that country. So the Netherlands, Switzerland, Australia, and some of them have gotten better. So I think we're going to see it come into the mainstream soon. Already we're using ketamine. We're using it at my clinic. And that's approved by the FDA. It comes in a nasal spray. So you have to be observed while you
Yeah.
take it. And that treats treatment-resistant depression. Ketamine is not a classical psychedelic per se, but it has some shared qualities. Yeah.
And it's still going to be here. We can chat and network. Please do stay, chat and network. And if you have any other questions, you can direct them directly to him. We will see you, inshallah, next week for the next of our Wellness Diwaniya. Thank you very much for your time.
Thank you for your time.
Can we just